Management of the first stage of labor by Jones H.M., MBADMS. Aims: 1. To monitor the maternal well-being. 2. To monitor the fetal well-being. 3. To monitor the progress of labor. Environment: if the cervical dilatation is 3 cm and below, the woman is admitted to the antenatal ward. A cervical dilatation of 4 cm and above will require that the woman be admitted to the labor ward. Ensure a clean environment, well ventilated, with good lighting. Ensure privacy, you can even use screens. Maternal well-being. Position and mobility. Nurse the woman either in the left lateral or right lateral position to prevent supine-hypotensive syndrome. Let the woman move up and about to promote descent of the presenting part. If she so wishes, she can sit in bed or on a chair to promote descent. However, if the membranes are ruptured, she should lie in bed and avoid moving around to prevent cord prolapse. Rest. Rest is important because it will give the mother enough energy to push the baby in the second stage of labor. Psychological care. Never leave a woman who is in labor alone. The attitude of the nurse is very important and can affect the outcome of labor. Welcome the woman cheerfully, with kindness, understanding and patience to keep up her courage and morale. Explain all procedures to be done on her. Allow the support person or husband to be on the bedside. A gentle touch and a smile will reassure the patient. Explain to the patient the findings of examinations done, especially the vaginal examination. Commend for the good things that she does. Be positive as you talk to the woman. Relief of pain. Massage the woman's back at the sacral region to relieve. Advise the woman to take a deep breath. In the early first stage of labor, analgesia such as pethidine 50 mg can be given as prescribed by the obstetrician to relieve pain and promote rest. Before administering pethidine, assess the cervical dilatation by means of vaginal examination to ensure it is less than 6 cm to prevent fetal distress. Ensure you document any medication given on the partograph. Medication. Combivir, a combination of zidovudine 300 mg and lamivudine 150 mg every 12 hours for mothers who are HIV positive and on ARV prophylaxis. HIV positive mothers who are on ART should continue taking ART the way they take it. Pethidine 50 mg before 6 cm cervical dilatation is prescribed by the obstetrician. Observations. Observations carried out are documented on the partograph. The partograph is used in the active phase of the first stage of labor. Monitor the vital signs of temperature 4 hourly, pulse half hourly, blood pressure 4 hourly. Do urinalysis on every specimen of urine. All drugs given to the mother are documented on the partograph. Intravenous fluids given to the mother during labor are documented on the spaces provided on the partograph. If the cervical dilatation is below 4 cm, the woman is admitted to the antenatal ward and vital signs are checked 4 hourly and documented on the chart. The partograph is not opened. Diet and fluids. Encourage the woman to take sweet drinks or light porridge which are easily digestible for energy. Vigorous uterine contractions during labor require a constant supply of glucose. If not obtained from the diet, the body will metabolize stored proteins and fat, which leads to fetal acidosis and uterine inertia. Let the woman take plenty of fluids to prevent dehydration. Record intake and output on the partograph. Do not give the woman solid foods because of delayed gastric emptying. Care of the bladder. Advise the woman to empty her bladder every 2 hours or whenever she feels like passing urine, because a full bladder interferes with descent of the fetal head, thereby prolonging labor. Uterine contractions become weak if the bladder is full. If woman is unable to pass urine, catheterize her. A full bladder can lead to bladder rupture. Hygiene. If the woman is in the early stages of the first stage of labor, she can have a bath. Change the linen frequently. If the woman is draining, change pads frequently. Advise the woman to wash her hands if she touches her genitalia. Infection prevention. Hand washing facilities should be available in the admission room to prevent infection. Sterile gloves and a sterile vaginal examination pack should be used to do a vaginal examination to prevent introducing infection into the vagina. Vaginal examinations should be minimal to prevent introducing infection into the vagina. Avoid artificial rupture of the membranes to prevent mother-to-child transmission of HIV. A sharp box should be available for dispersal of sharps. Decontamination of used instruments in JIC 1-6 should be done to prevent infection. Fetal well-being. Monitor fetal heart sounds half-hourly, note the rate, frequency and volume. The normal range is between 120 to 160 beats per minute. If above 160 or below 120 indicates fetal distress. Use a Pinard fetoscope or Doppler to check the fetal heart sounds. The liquor and membranes give information about fetal condition. After rupture of membranes, normal liquor is clear. After each vaginal examination, take note of the color of the gloves to note the state of the liquor and plot on the partograph. Dark green meconium will indicate fetal distress. Absent liquor may indicate ruptured membranes. Then listen to the fetal heart sounds. Check for molding and caput formation to rule out fetal brain damage. Record on the partograph the above information. Progress of labor. The first vaginal examination done in the active phase of labor should be indicated on the partograph. The cervical dilatation should be documented as X on the alert line and time should be recorded on the space for time. If labor is progressing well, the plotting for cervical dilatation will remain on the left of the alert line. Descent is determined abdominally. The nurse puts her hand over the fetal head. If all fingers cover the head, it is said 5/5 above the brim. Descent is assessed every 4 hours. Note the length, strength and frequency of uterine contractions. When you place your hand on the fundal part of the uterus, note the hardness and classify the contractions as mild, lasting 20 seconds, moderate, between 20 to 40 seconds, and strong, 40 to 60 seconds. Observe the contractions every 30 minutes. Count how many contractions there are in 10 minutes. Preparation for the second stage of labor. Towards the end of the first stage of labor, the nurse should make preparations for conducting the second stage of labor. The delivery room should be warm, clean and ensure privacy. A resuscitator, oxygen, suction machine should be available. Prepare the baby cot as well as the baby layette. Prepare baby's identification band. Provide a sterile delivery pack and episiotomy pack for use during delivery. Find an assistant to help you conduct the delivery. Complications that can occur during the first stage of labor. 1. Fetal distress due to reduction of blood flow to the placenta or fetus, such as hypotension, hypertension or due to cord compression. 2. Prolonged first stage of labor due to factors affecting the progress of labor, e.g. condition of the powers such as malposition and malpresentation of the fetus. 3. Maternal distress due to prolonged labor or any other cause. 4. Cord presentation. It exists when a loop or loops of the umbilical cord lie below the presenting part of the fetus with membranes intact. Can be due to malposition or malpresentation, cephalopelvic disproportion where there is ill-fitting presenting part. 5. Cord polyps exists when a loop or loops of the umbilical cord protrudes through the cervix into the vagina or vulva with membranes ruptured. Is due to ill-fitting presenting part. 6. Antepartum hemorrhage either due to placenta previa or placenta abruptio.